Congratulations, Laura, for this beautiful presentation, and to all the team for setting up this very innovative technique in order to move forward for personalized treatments and therapies. Thank you very much. So this session is now open for questions and discussions from the audience.
Hi, quick question. Do we have any idea about, because I always consider this environment to be a very highly hypoxic environment, and clearly there's a great danger we can change genes that are the cells used to prevent them against that hypoxia. Do we have any true idea what it is in the tumor environment when you're doing these models? Has anyone ever tried to put a probe into the perihilar lesion to see? Because we can estimate what it is from the hepatic arterial blood, but it may be very different inside the tumor.
Not to my knowledge, but you guys know?
So say what the tissue oxygenation is like actually inside the centre of the tumor?
Yeah, it's what you're trying to model too, because I don't know, and I'm just asking, do we know that?
No, so I don't think there is any data to know. I don't think we do know that. So I think what we've tried to do is get a model that's as closely representative to. It's the closest that we can get to what we feel like it's going to be within the tumour. But you're right. I don't think we have an actual baseline that we can aim for. If you see what I mean.
I suppose my other question was, when you're doing your experiments, will you do a series of transcriptomic time points to see how does it change dramatically? Because if you don't do it at baseline and follow it through for 7 or 8 days, a one-off may not capture that change that you're seeing from the time it's surgically acquired. So that might be quite important too.
Yes, that's the plan. So at the various time points that we've been looking at the viability of the cells, we save the slices at that time point, such that we can.
And the total transcriptome, I suppose. As
yeah,
well.
So that we can then go and do those sort of analyses at those time points. Yeah.
Thank you very much.
Thank you.
Hi, thank you. It was a really interesting talk. My questions are for Laura, because I'm always very interested in any pathway that involves getting pathological samples from the lab to from theatre to pathology. So my first question was, for non-mass forming tumors, how do you navigate getting your slices from those kinds of specimens? Because if it's a mass, then presumably you can just do like a punch biopsy and get a sample out. But if it's, for example, if it's something that's periductal or not mass forming, how do you manage that?
I think you're
Do you
probably
want
best.
to?
Yeah.
So they're my hands in the pictures of cutting up those specimens in the theatres. With difficulty, to be honest. So the ones that we've been able to sample so far, because it's the volume of tissue that you need, are either the intrahepatic, obviously, split the liver and open that onto the tumour, but the hilar cholangios are much more difficult, and the ones that I've been able to sample so far have been the mass-forming ones. So again, we work very closely with our histopathology colleagues up in Liverpool, and they're happy for me to open the specimen there. We've worked very closely with them to ensure that we're respecting the margins of the specimen as best we can. Particularly, obviously, that goes back to the what remains within the patient. So at the moment, the slices we generated are from those mass-forming hilar cholangio ones. When I find one that is truly sort of ductal infiltrating, I'll let you know how we get on. But with difficulty, and that's why when we looked at that way to try and generate slices out of an agarose plug, because it may be that I only get a very small amount of tissue that can't be held within the cores if you've seen. So we have sort of practiced with that, but then the difficulty then comes with that in trying to ensure that you've got slices that then are uniform across, and that's why we're exploring how we can normalize those different size slices to weight, because obviously you're going to have different sizes.
Okay.
So yeah.
Brilliant, thank you.
Can I just add that we're also going to explore being able to prepare slices from tumour biopsy samples, actually. So obviously with a lot less tissue, but that's something we want to explore in the future.
Yeah. So trying to certainly for those that aren't small specimens, whether or not we can take a true cut from that, so you get a much smaller core of tissue. And again, by using the way in which we bed the tissue in the agarose, we could embed multiple tissue cores together and then slice those. But again, what we're not sure at that stage is what the viability of those smaller discs of tissue will be. But it's something we've thought about.
Okay, thank you. Sorry, I have another question, if that's okay.
Yeah.
And actually, that leads on quite nicely, because Laura, you mentioned that you're looking at viability by histology. So I'm assuming you're going to look at things like necrosis within the tissue. So some of the work we did with one of my previous master students actually showed that when you assess necrosis on just by bundle histology, and you try to correlate that with outcomes in patients, a lot of the outcomes and biological processes were very different if you looked at different parts of the tissue compared to if you looked at the tissue as a whole. So I wondered whether you had plans for taking that into account. So essentially what we've seen is if you have a piece of tissue and you get a pathologist to assess it as a whole piece of tissue, you get one outcome.
Yeah.
If you get a pathologist to assess the center of the tissue where presumably you will have more necrosis, you have a totally different outcome. And on the outside, that's more oxygenated, you have a third outcome.
Yes, we are aware of that.
So again, that comes down to how we prepare the slices. So again, if enough tissue is available, then we do take cores from multiple areas of the tumour. So we're looking at the periphery and that within the centre. And then when we actually incubate the slices, we incubate them randomly in triplicate. So we're trying to get a representation of different areas of the tumour within the slice model when we do that, to try and mitigate some of the issues that you're talking about. But part of the thing that some of the data that we haven't seen is again looking at slice viability, because we've got one on the moment, is that where we sample the tumour does matter. So we've seen that the viability in the tumour slices that we've taken around from the periphery of the tumour tend to be much better than if we've taken it right from the centre, because of the effects that you say with the fact that the centre of the tumour is much more likely to be necrotic or just stromal tissue. So that has made a difference to some of the viability of the slices we've noticed. That's anecdotally at the moment. Cheers, thank you.
I just have a technical question, which is...
Please,
sorry, I just have a technical question. It was just very interesting. When you just do MTS assays to determine the viability, whether you could really assess which cells are remaining viable within that tissue, because you have all types of cells all together. They're not, you're just getting an average view across everything. How do you know what cells are doing what? Do you do follow-up studies to look at specific cell types and to show that subpopulations are remaining viable? I mean, maybe Izzy already sort of asked.
So the
kind
actual
of question.
slices we conduct the MTS on, obviously, certainly within the tumour tissue, they go purple anyway, but we collect that exact slice into formalin, and that's what we're doing the histology on actually. So we are looking at proliferation, cleaved caspase, H&E staining on the same tissue. So we are able to visualise some of the cells that are remaining viable.
So you co-stain for specific markers and do that afterwards? After you look at the average MTS signal?
So we take because we do in triplicate, and we do the MTS assay, look at the overall viability that we've got for those, but then we you can't hear me. Sorry. So we so of the slices that we then do the MTS assay on, once that's done, those slices we then store, so either snap freeze them or we put them into formalin for embedding for histology. And when we look at, the plan is to look at markers of apoptosis and proliferation within that, stain for the different cell types. So as you say, we can see which of those cells are dying, because contributing to the MTS assay. Because what we don't know at this stage is, as you're right, is putting the tumour tissue into culture. That's a traumatic process in itself, and we don't know whether or not that adversely affects different cell populations. So are your immune cells going to be the ones that have died off, but your tumour cells are more robust, or vice versa?
Yeah.
And that's work that we're going to be doing, sort of mainly on a histological basis, looking at different cell populations that are present, which of those have markers of apoptosis, which of those are alive, and would infer from that which cell populations are the ones that are producing the colorimetric change on the MTS assay.
Right.
So
Thanks.
just to follow on from that, Ray Young's group did actually follow the slices, and they have published that there is obviously initial drop in viability, certainly within the tissues, and it did affect the immune cells. But from day 3 onwards, they are improving, then they're sort of returning to normal for whatever that normal is. So we are expecting a drop off initially, but it does improve with time in culture.
Okay, thank you.
Thank you. Next question, please.
Just a quick question on sequencing. I mean, obviously, we've seen what new knowledge we gain from sequencing the perihilar cholangiomas. They're often underrepresented, aren't they? I mean, do you ever feel if the UK was going to concentrate its efforts, what number do we need to get up to sequence before we start to saturate our knowledge?
Good question. I don't know. I mean, obviously it was a fairly small series that we conducted, but you could already see within that there's some significant differences to what's been published before. And I think you're right, is that those publicly available data sets, probably there is an overrepresentation of intrahepatic cholangio within those. So I don't know what number we'd have to get to say sort of that we've got a really confident idea as to what the mutational profile is like within sort of a UK Western cohort in higher cholangiocarcinoma. Maybe the guys down here would be better at answering that question.
I'm just going to probably throw that back to Juan, actually, because no point in doing this unless it leads to something else. And ultimately, there has to be patient benefit, as part of a clinical trial. I mean, John Primrose, I was talking to him yesterday. I think he might have left. I know John Bridgewater's there. The BILCAP translational work is ongoing. In that, there's probably about 100-odd perihilar cholangiomas. So certainly the Liverpool series in terms of quality data will be similar to that. But ultimately, it's no point having all this information if it's not going to lead to practice-changing trials. And that's really up to Juan. And I think we are due to have a meeting in the near future about adjuvant therapies and trials and things like that.
Thank you.
I was actually going to ask a question of my own, which follows on from that. And obviously, this is a very precious series because we know that it's difficult to get this tissue in perihilar cholangiocarcinoma in surgically resected specimens. In real life, we know that it's nearly impossible to get tissue, and certainly enough tissue for profiling in patients with advanced disease. So how do you think we're going to be able to do this if we are, for example, we're going to be looking for mTOR, pathway-driven mutations?
I mean, I think that's really through collaborative efforts, really. So we've clearly shown what the profile's like within our cohort. But I think that's obviously only further validation work, and the only way that you can do that is by achieving a mass of samples. So working with other groups, we could sort of improve the numbers in that. But I think that's probably the only way that we can do that, just through collaborative effort. Because as we know, as we've seen, it can be difficult at times to reach the number of or to get the number of samples that are needed to reach that significance level. And in a rarer tumor like that, it's really important that we work together to try and improve those numbers.
Well, it's not so much about building up the collection of samples, but for an individual patient, getting enough tissue to undertake the profiling.
Okay.
Yeah, how are we going to deal with that one? Because that's a very real problem on a day-to-day basis.
Yeah, so I suppose we've gone from resectional specimens, and obviously there are going to be those that don't have that option. And I've seen that those relying on small amounts of tissue from biopsies, from ERCPs and so on, and that tissue is precious because that's obviously going for histology as well. It's needed for that. So I don't really have an answer for you, I'm afraid. It's sort of how we could do that, but it's an important question.
Hassan, how are we going to get more tissue? you want us to do the trials. We need to do the tissue to put the patients into the trials.
I think the advantage to surgery is it can get you tissue, and it doesn't matter what you're doing. Okay, maybe slices, it might be organoids, it might be something else, but you need to work with your pathologists. I mean, these guys are the key. Our pathologists are allowing us to cut up the tissue in theatre. As soon as the specimen is out, Tim's there taking the sample, potting it and driving it straight to the university rather than it going through the path department. Certainly for the perihilar tumours, these operations often finish well after 5 p.m. The lab is shut. The path department is closed. So we're having that kind of system in place. And what I mentioned about the protocol, which is now on the portfolio, there's nothing to stop other centres taking it on. And like I say, Cholangiocarcinoma UK or whatever enthusiasts. I mean, we have a number of centres in the room. There's no reason why we can't have 5 or 6 centres that are doing reasonable volume of this surgery in the UK to say, look, we need to, I mean, it's precious for that individual patient, but also for our future knowledge, which will help ultimately other patients, But it's easier from a surgical point of view, and that's why adjuvant studies perhaps are easier with high quality tissue, but in the palliative setting, it's more challenging, and it'd be interesting to see how that's been cracked for ABC10, because obviously that is going to be the big study.
I think that if I can add a comment, probably we should use these fully clinically annotated academic series to see what is the matching agreement between a liquid biopsy and the tissue biopsy, so that maybe we can translate into the metastatic setting.
Especially with the TMB data, that looks so interesting.
Yeah, and then you can monitor, the relapse and see if we really can see the same mutations coming up.
Well, thank you very much, all the panelists and all the audience for the question and very nice discussion. Congratulations for this excellent work and good luck in the final of the Champions League against Real Madrid.
I live in Manchester, so it doesn't matter.
Thank you.
We keep going.